standalone jobs prior to settling into a training program. It's still vaguely possible now, but it's much less so because it's all so much more structured. I suppose that'd be equivalent to the FY3 year. So I left, as I say, I left Edinburgh. I ended up doing about 9 months of peds, about 9 months of A&E, and during that time, I moved from Edinburgh down to London. I did 6 months of A&E in London, and then moved on to anaesthetics. Along the way, each time I was like, I really like this is great, thoroughly enjoying it. Looked around me and saw what was going on, really thought it was great, looked at what the consultant's doing, thought, yeah, okay. I thought, well, it's quite hard work, I'm not entirely sure I'm getting out of it what I wanted. When I arrived in anaesthetics, I just went, oh, this feels quite nice, I quite like this, I'll just stick with this, and so I did. Now, full disclosure, part of the problem part of the reason I was more aware of anaesthetics than most was the fact that both my parents were consultant anaesthetists at the time. Albeit they had said, don't be a doctor, you fool. But once I said I want to be a doctor, they got right behind me. And so I wanted to do that last in an effort to not follow them into the family business, but as it turns out, I did. Whether that is partially character-based, I'm the son of my parents, who knows, but it just seemed to work. So I got myself an initial training post in central North London. There are currently, it's one overarching school, but 5 sub-schools within London. And then I got a specialist registrar post subsequent to that, all done rotating around in and around North London. So I'll tell you about how long that takes in a minute. I did a locum consultant for 1 year, then I became a substantive consultant back in 2008, which means I had a permanent job at Guy's and St Thomas's hospitals. About 10 years after that, actually 11 years after that, I became a college tutor. So that's actually within Guy's and Tommy's rather than within the college. And what that meant was that I looked after a subsection of our trainees. And because we're such a vast place, I was looking after about 30 of them. And then after 2 years of that, and I ended up doing for 4 years, I became the lead college tutor. And so I've just finished my term, just stepped down of looking after all of our trainees, ensuring they were getting the right training in various bits and pieces, the right modules, the subspecialities, making sure they had the right rotas, they were being looked after, overseeing all our educational supervisors. Which, if you are medical students, you'll be aware of educational supervisor, I think, as part of your medical schools. That then carries on through when you're doing specialist training, albeit usually most places you get a more of a lesser number. Actually, it depends on which speciality you get into. And so for the sake of argument, IT or ED, you might end up with 1 to 6 or something like that, whereas we have more like 1 to 2, not least because there's more of us. So that was me stepping down from college tutor, which now leaves me just as an ordinary consultant anaesthetist. That said, I'm still knocking about in the department helping the guys. I've just taken over because there's theoretically a lot of knowledge in my head as to how it all works, how people rotate around and that kind of stuff. So that I am still being useful-ish, I think. So that's me. It brings me on to why anaesthetics. And so why anaesthetics in general? I've just thrown some stuff at the wall and see what sticks. First up, team working. We are always working in a team, not least in the UK, we have an anaesthetic assistant with us the whole time. We're theoretically not allowed to do any anaesthetics without our happy helper. And that is different to an anaesthetic associate. So they are not the same as ACCPs or anything like that. They are a different beast. We've got far few of those in anaesthetics at the moment. So we always have our anaesthetic assistant, and of course we work in a wider team, a theatre team, both with the theatre nurses, with the surgeons. So we're spending a lot of time troubleshooting within them, helping make sure the list runs correctly, working on the order and all sorts of stuff. Another aspect of anaesthesia I like is the immediacy of it. So notwithstanding any planning that we do, particularly in the mornings once we've finally seen the patient, the vast majority of what could be called my interventions, so either the drugs I give or the airway manoeuvres that I take or the regional blocks that I do, knocking out an individual limb, or the lines that we do, we get early feedback. I mean, the majority of the drugs that we give work within seconds. And so we're not doing as some do, seeing people in clinic, giving them some drugs, waiting 6 months and seeing what it's like 6 months later. Very much more immediate. That said, peri-op medicine, peri-op anaesthesia is moving much more to the forefront where it has been over the last 10, 15 years. And whereas we used to do that 20 years ago a lot more, that then fell out of our purview for a bit, and it's now very much back on the radar. So a lot of anaesthetists getting much more involved in pre-assessment, optimization, prehab, that kind of stuff, and then care in the immediate pre and post-op period. Anaesthetics is a large, well-organised speciality. We're often unseen within the general population or within even within medical schools. But we have
Dr.
fingers
Thomas,
in
I'm
great.
so sorry to just interject
Hello. Yep.
seconds.
Yeah.
We've just had about 20 people join in the last couple of minutes.
Oh, cool. Yeah.
So I just wanted to quickly say to everyone that if you are hoping to apply for anaesthetics, I'm an F2, like in the application stages at the moment. I really recommend taking notes on this kind of what Dr. Thomas is saying, because they will ask you about commitment to specialty. And if you're able to show insight and commitment, this is exactly the kind of insight, like what he's listing right now, 1, 2, 3, 4. Not all of it might resonate with you, but being able to reflect in an interview and saying, I attended a careers talk from an anesthetic consultant, and I reflected on the fact that, instant feedback, which contrasted to medicine blocks that I hadn't enjoyed as much, that shows like real critical thinking and that you've really analyzed different aspects of the profession. So although it probably feels like a really long time away and medical school interviews felt like a long time ago, these are like really important skills and things to take with you looking ahead to like later interviews. And if you just take little notes on your laptop and just store them away in a place, in like 3 or 4 years' time, a year's time, 5 years' time, you'll be so grateful to past you. So I'm so sorry to interrupt there.
Yeah.
I'll put little like hints and tips and reflections in the chat as he's talking, but I just wanted to bring that in. And yes, it is recorded. Sorry to interject there.
No, Megan, do that anytime you feel like, if I'm flowing, just go, wait, stop up and chuck stuff in, or indeed questions. It's no, I'm not precious, you know me. So large, well-organised speciality, fingers in loads of pies, and essentially we're the largest hospital speciality without necessarily a lot of people knowing we exist. Which means that we can actually get an enormous amount of variation within our. I'm just turning my thing on to do not disturb. Thank you. Sorry. There's a lot of variation within anaesthesia potentially. So in very simple terms, we do general anaesthetics. So we knock people out for operations or for or procedures or what have you. There are various methods within that, various drugs we can use. And there are definite variations as to how we might do it depending on patient differences, operative differences, or indeed the situation where we're in or the resources available to us. So we got those variations, what airways we might use, what have you, to look after people. We can do regional anaesthetics either as a standalone or in conjunction with a general anaesthetic. And what do I mean by a regional anaesthetic? What I mean by that is we can put local anaesthetic beside either a central nerve, i.e. just beside the spine, or more peripherally out into the limbs or torso. And we can knock out a section of the body, which still I find a little bit weird, but it's quite a good laugh doing it. And it can be tremendously satisfying and quite surreal to watch sometimes, watching operations on people who are wide awake. And that can sometimes just be for the pain relief after the operation, particularly if we're doing it with a general anaesthetic. And then, of course, there's sedation, which is a bit of You could call it a general anaesthetic light, anaesthesia being a spectrum, arguably. And the sedation needs to be done with care. We have a lot less control of the airway and the physiology, potential physiology of the patient. So it's something which is historically bandied around enormously in other places, like radiology or in ED, in A&E. But anaesthesia has taken a lot of it back from a safety perspective. So all that is done in theatres, it's done in labour wards, it's done in interventional radiology, as I said, CT, MRI, all sorts of places in the hospital. We also do intra-hospital transfers or even the inter-hospital transfers, so between hospital transfers. That tends to be the anaesthetic team because it's airway related in terms of it tends to be anaesthetised patients that are being transferred across like that. Or at least, sorry, there will be a lot of people being transferred about who aren't anaesthetised. But as soon as you have, for example, an intensive care patient who needs transferring, or somebody with a bad head injury that needs transferring, then it's somebody with the proper airway skills, and that's with the airway guys, basically. It's also worth noting on that point that anaesthesia is one route into proper out-of-hospital medicine, pre-hospital medicine, such as the helicopter emergency medical services. But that is quite niche, I would admit. Very cynically, as an aside, and this is not something you necessarily think about now unless you're very forward-thinking and possibly a little bit avaricious. If it's important to you, then anaesthesia, there is a good opportunity for private work within anaesthesia broadly nationwide as compared to some other specialities. Like I can't imagine there's a huge amount of work for respiratory physicians in the private sector unless you're based in London. I don't know, that's personally it's not important to me, but I'll put that out there. There are loads of other reasons that I can't think of immediately off the top of my head why anaesthetics, but that's some of the ones that I've thrown up. Feel free to ask me more questions later. For me personally, why anaesthetics? Well, I've already mentioned the family connection. I'm possibly the only consultant working in the UK today who was taught to intubate by his father. But why for me? The team working and immediacy, as I mentioned above, even if it's nominally a boring list, it's the team working with everybody in theatre. It's great. And also, whilst the joke is obviously that anaesthetists become anaesthetists because then we don't have to talk to the patients, we actually in real life have a short, sharp opportunity to, with the patient, get information about their past medical history, gain their trust, impart the information of the plan to somebody who's usually nervous and possibly not paying full attention, and answer any questions as they arise, that they raise. I think it's a tremendous honour for me, and indeed all of us, to be helping people when they are as vulnerable, and to take on the responsibility of looking after them, both from arguably from a physiological and awareness perspective, but also setting them up to have a good experience during and afterwards in terms of pain relief. That particular meeting takes as long as it takes. It might take as little as 5 minutes, very occasionally less. It might take an hour, depending on the complexity and how much digging we need to do. And one of the nice things about me being an anaesthetist is it takes as long as it takes. There are plenty of time pressures, and we can get a little bit stressed about it all, but things don't move on until I'm satisfied. If I want to wait to start the list, then I wait to start the list. It needs to be right. So we do lots and lots of communicating on all sorts of levels. So the two parts of why anaesthesia is good is, one, the work-life balance. Generally speaking, I think anaesthetists have a better work-life balance than a lot of other doctors. Some of that is, or a lot of that is down to the fact it's sessional. Now, what I mean by that is the fact that it cuts both ways. We don't have continuity of care. So I turn up in work on a Monday morning, and I do my work for Monday, and then I go home in the evening, and I can essentially sort of forget about everything that went on during the day. Obviously, there's some processing and reflecting going on, but I don't need to think about, what I need to do with that patient tomorrow, the next day, the following week. Weekends, I'm away, I'm enjoying myself. So that's good. And also that means, so holidays you can turn off, generally speaking. That's wonderful. It also, if part-time, will ultimately be a potential. And that is, in the modern era, that's changing norms. About 10 historically it's been ladies having children. It is because it's sessional, it is generally easier to go part-time in anaesthesia than it is in a lot of other specialities. You can legally in all sorts of other specialities, it's just physically easier to do it within anaesthesia than many others. Now, there's all sorts of other sessionals that fall within that, so ED, radiology, all sorts of, but it does work. And also, ironically, whilst we're often not seen as doctors, particularly out with hospitals, we are generally very well respected within the hospitals. And there's possibly a certain cachet to being an anaesthetist, which just feels nice. In particular, people tend to relax more in a drama when we're around, and that's part of the reason. Part of the reason for that is the shape of our training. Quick disadvantages: we are a service industry. We tend not to lead patient care as such. We do, but not obviously. So that can grate on some people's egos. Flip side of no continuity of care is you have to work hard sometimes to find out what has happened to the patients who were interesting. I mean, we can, but you just have to work a bit harder. And indeed, it's not always exciting. It's certainly not all fireworks the whole time. There are certainly moments of it, and there's the old, again, another cliche is airline pilots, lots of boredom with occasional, so 99% boredom with 1% sheer terror. We don't do sheer terror because we're better than that, but it can get a little bit sweaty at times. However, I personally perceive it, even the nominally boring lists, I'm still working the list right and communicating with the team, and that is not just the anaesthetic, it's the whole experience of, for me, being an anaesthetist. And so it's never really it's never boring as such. It's just not always fireworks. So training, what's that all about? It is, once you have done foundation training, then you get the opportunity to try and join speciality training as an anaesthetist. And there's two ways to join speciality training. Either joining stage 1, or core training as it used to be, as an anaesthetist. Thereafter you do, whilst you float through various other subspecialities, you are an anaesthetist the whole way through, unless you also decide to dual later on. Or there's a thing called ACCS, which is Acute Care Common STEM, which if you search up Acute Care Common STEM, they've got their own, it's not a college per se, but their own school and their own websites. So what the Acute Care Common STEM does, it's called a common because it includes intensivists and ED physicians. Used to have acute medicine as well, but I've not seen any acute medics doing ACCS for a long time, so I have a funny feeling they don't do it anymore. So on the one hand, pure anaesthetics is a 7-year training program. It's currently broken into 2 parts, so you do 3 years, then you have to reapply for ST4. The college is apparently looking at making it run through, which some specialities do. They did do that about 15 years ago, then decided not to again, but apparently the pressures have meant they didn't want to do it again that time, are now going away, so it might become run through, which will make the ST4 year a lot less stressful. I'm sorry, the ST3 year a lot less stressful because you wouldn't need to apply for ST4, but currently you need to reapply. Now, one of the reasons reapplication is potentially required is ACCS, because what ACCS is rather than the 3 years of anaesthetics from the start, it's the 4-year training, whereby the first 2 years you rotate for 6 months through ED, acute medicine, ITU, and anaesthetics. ED and AM will be in either order, but they'll be in the first year. And anaesthetics and ITU will be in either order, but they'll be in the second year. And thereafter, for ACCS CT3, the ED physicians go off and do their own CT3 and carry on. The intensivists go off and do their and carry on. And the anaesthetists then join anaesthetics, They are CT3s, but they are the equivalent of CT2s, but slightly different. And they then carry on from there. So they then do 2 years of pure anaesthetics before they then also get the opportunity to join ST4. The advantages can be argued either way. I personally quite like the idea of ACCS because it fits more in with my experience and my general idea of people getting a general idea of what's going on. Now, the one caveat I've got in that is that don't go into ACCS thinking that, oh, I can join ACCS and then pick at the end of CT2 what I want to do, because unfortunately you do join it as an ACCS with a root speciality. And so ED physicians will go in and they'll do the first 2 years and they are nailed down to go into ED and all the rest. So if you do then want to convert, and many do convert, particularly into anaesthetics, that's a whole different story, then you do have to step back down again, which is a bit of a pain. Some of it does, you can get some of it counted, but you will probably need to do at least 1 of the 2 years in terms of time again, which is a bit of a pain, but it's doable. So you lose a year of your life as such, but by then you will have a better idea of what all 4 specialities are like, and it gives you more informed decisions. So I wouldn't say don't do it, just be aware of the fact that you lose time.
Just to quickly interject here from
Yeah.
an F2 perspective, you often will have an F2 job in ED, whereas you don't really get an anaesthetics job in F1 or F2. So if you're on the fence between anaesthetics and ED, I really recommend doing your taster week in anaesthetics, because this is also another way to show commitment to specialty. Another thing that you can do is foundation priority programs. So this is, if anyone doesn't know, where you can be guaranteed a job in a specific location that is less desirable. So if you don't have like family and friends ties, if you're not too bothered about being in a big city, you can go somewhere a lot more remote and choose a job, say for example in like, I don't know if they've got an anaesthetics one, but like Dumfries, Yeovil, Sunderland, places where they struggle to recruit doctors as much, but they give big incentives like research projects or a guaranteed block in anesthesia or teaching experience in anaesthetics. So you can, if you're dead cert that you want to do anaesthetics, definitely look into foundation priority programs in F1 and F2, because it's a really good way to like guarantee that experience. Um, um, Sorry to interject there, Huw.
Oh,
Please.
no, not at all. That's ideal.
Oh, someone just said Leeds/Wakefield had anaesthetics foundation priority program this year. So yeah, guys, it's really worth looking into foundation priority programs, because it's a really good way of getting experience if you don't mind too much where you go.
Yeah, I didn't know that existed. That sounds very good. And indeed, that Megan raised a good point. I didn't mention foundation anaesthesia at all. It is rare, but it does exist. Just to give you a vague idea of the numbers, we've got somewhere in the region of 150, 170. Nobody really knows. Consultant anaesthetists at Guy's and Tommy's. I do know for a fact that including non-HE trainees, we've got on our books about 180 of them in department at any one time. We've got 100 residents, and we've got 2 FY doctors, FY anaesthetists. So there's not many of them about. And we've had a couple come through over the years who are very engaged, very switched on, and I'd be amazed if they didn't get themselves an anaesthetic job in the future. And we've had a couple along the way who are completely disinterested and disengaged, and it just makes me sad that they're wasting the slot. But hey ho, some it's just the luck of the draw. I completely accept that point.
We've just had a really good question here, which
Yes.
segues really nicely. I am an F1 about to rotate into anaesthetics for my 3rd post.
Yeah.
Amazing. You're one of the special ones. How do you suggest I make the most of it?
Just get stuck in, get involved. Look interested, be interested. Don't imagine yourself as to an extent. I have no idea what your shift structure will be like, because the ones we have is that they don't do on calls with us. They do on calls, but they do on calls in vascular. But during the daytime, imagine yourself as a CT1, as it were. Get thoroughly stuck in. As time passes, you will probably end up spending a lot of time certainly with a bit of luck, with a similar group of consultants. And as they get to know you, then encourage them to give you more autonomy. I was going to lead on to in a little bit. In fact, I say it now. The vast majority of teaching within anaesthesia is one-to-one teaching in theatre, and you'll be getting that as an FY in the same way that any anaesthetic trainee gets. So just sponge it, just suck it all up. Be keen. What am I thinking of? So part of one of the most useful things early on that anaesthetics trainees can do is to do the preoperative assessments on the day. You can get involved in the pre-op assessment clinics, but on the day it makes consultant anaesthetists' lives a lot or other residents' lives a lot easier. We can stress less about the turnover of a list. If somebody says, "Oh, I'll go and see the patient if you like," I'm like, "Yeah, off you go." And then you come back and present them to us, and we make plans and all that kind of stuff.
One thing I was maybe just going to add from
Yeah,
a foundation doctor's perspective, like working in it now, the thing that is the best to do is be proactive. Because if you, in the first month, show your seniors that you can get jobs done efficiently and they can trust you, then they'll be much more likely in months 2, 3, and 4 to give you those opportunities. But it's really important to recognize that you have a specific job to do. And if you're kind of always there, like, not doing the job, then they're not going to be able to let you come off and get those extra opportunities. And in my experience, where you get the very best from the job is when you gain the seniors' trust as a foundation doctor. They know you can smash out a day's worth of work in a really efficient morning because you work hard, you're proactive, you're efficient, you ask the right questions. And that then gives you 3 or 4 hours where you can grab a bleep, go to theatre, grab a bleep, go to the clinic. Then, after you've got more experience in the theatre and the clinic, you can say, "Oh, I've seen you like intubate 4 or 5 times now. I've watched a few YouTube videos. I've written a reflection about it. Please, could I have a go with some help?" And then they can always say no. Or you could say, "Can we go and practice on a model?" And then write a reflection about it. And that evidence over time builds up and up and up. And then when you finish the block, they say, "Wow, you were incredible. You were so proactive. You did all your skills. You got involved." And then you can then go to the interview with that as your evidence that you've built over time. But my biggest piece of advice is make sure you spend the first month showing that you can be a good F1 in any job that you guys do, because otherwise you can't get the cool extra stuff. You've got to like earn your stripes a little bit.
yeah,
Sorry.
Megan. No, Megan, that's excellent advice, and I absolutely agree. And that stands for all specialities. Absolutely, definitely. Um, Megan also mentioned tasters. She's absolutely right. I forgot about tasters. We had tasters people coming through. It tends to be easier to organise it within a trust that you're working already, but there's much more paperwork involved. But you can do it in geographically different places. So that is definitely shows willing, shows interest, and I'm sure it looks good on a CV. Whether it scores, I don't know. Project-wise, you could potentially do that. Both certainly you could do it as an FY within anaesthetics for sure, but you can likely do it. You can do them as medical students as well. That would either be back in the day where you had special study modules. I don't know what they're called now, but you can try and get involved in one in anaesthetics, or you can just go along to approach an anaesthetic department and see who's in charge of find out who's in charge of either their quality improvement projects or their audits or what have you, and try and get involved that way. Just say, "Oh, can I please? Oh, hello, I'm interested."
Huw, just a quick
Yes.
question here, sorry. So I've put a link in the chat to the QI compendium, which is such a helpful link as a trainee because it shows all the specialties and all the things they do QI projects in. Guys, you might not know this, but as an F1 and an F2, you have to be involved in a QI project. So if you're on a ward where there's anesthetic doctors, they are having to do QI projects, like they are doing QI projects as we speak. So if you can find like core trainees in anesthetics, they will be doing QI projects. So again, just like approach them in the right way. But this link that I've just put in the chat kind of lists all the different specialties, like subspecialties and the QI projects that they do. I'd be really interested to know, Huw, I'm looking from the bottom up and I don't really know, but from the top down, how does QI work from like a very senior level?
Oh Lordy, embarrassingly, whilst we're all supposed to do them roughly once a year, I haven't done one for ages. We have I'm very, very lucky at Guys and Tommies. We have a bunch of guys who are hyper motivated, very organised, and we have QI leads basically, and they sit there and they come up with loads of projects. And in fact, we've got one guy who's going regional. Ultimately, he'll go national. He's amazing. He's big in the college, and he set up projects such that people can rotate in, carry on with a QI project that's been ongoing, and then rotate out and possibly continue the same project in a different hospital, but at the same time somebody else comes in, and so it's not in the what or the major downside of everybody needing to do QI and audit every year is that we used to just poop out absolute rubbish just to get a tick box. I've done an audit. What Joe's trying to do is massively increase the quality of what goes on and usefulness of what goes on. And it's not just Joe. So there will be a QI lead in every department, quite possibly any speciality what you have. But I'd be amazed if an anaesthetic department didn't have some form of QI lead. And if you can find
One thing that I just add to this, from an F1, F2 perspective, it is your educational supervisor's job to make sure that you build your CV. It is literally a part of their description. So if you email them at the start of F1 and say, I really want to do anaesthetics, please could you put me in touch with the QI lead for anaesthetics or one of the training team, and I can then get involved with some of their projects. It is your ES's job, and if they're not replying, then raise it with your foundation team because they're there to help you get these opportunities.
For your entire medical career, you lean on your ES. That's what they're there for. They're there to. I mean, the word supervise is arguably a bit dictatorial. They're there to guide you, to help you, to hold your hand through bad times, to celebrate your good times, but more than anything else, to act as a resource. And a potential help to find your way through, and yeah, they will have more contacts. They'll be able to find people. So structure. So we've done stage 1, as it now is, used to be called core. That's 3 or 4 years, but 3 years. Then there's a further 4 years. Now there's a cut-off point at that point. It's called a critical progression point. You do need to pass your primary Fellowship of the Royal College Anaesthesia exam before you can enter ST4. You can't do it without. So that's a critical possession point. The anaesthetic exams are widely regarded as a pain in the arse and quite hard to pass, but there are a lot of resources available, and it's just a question of knuckling down and doing it. And they do ask some really stupid things like how lasers work, but a lot of it is very useful and very important. And I do wonder if some of it is just that we have, it's ridiculous one-upmanship about the fact that we've got very hard exams, and we should keep our very hard exams because we have very high standards, don't you know? And in fact, the ED exams have also got a little bit ridiculous, possibly because they're the parvenus. But anyway, that wasn't me trying to be nasty. It came across a bit nasty. My apologies. Then so that is then. I'll come to the research in a minute. Then, having got into ST4, then there's another critical progression point at the end of, after a further 2 years. So stage 2 is another 2 years. You've got to have done, that is subspecialty training and some extras. So that's peds, cardiac, and intensive care, 3 months of each. And you have to pass your final FRCA before you can move into stage 3 for the last 2 years of training. So there's another cut-off point there. It is very unusual to get thrown out, and most people get the exam eventually, but some people do get stuck there for a year or so and need an extension to training. The good news in terms of exams is the fact that is then the exams done, unless you want to go off and do something else, because there are some European regional exams or what have you, or move into ITU as well. But anaesthetics doesn't have exit exams, unlike many other specialities. So once you've made it into SD6, you're done with exams, which is a big relief, possibly earlier. During all this time, you'll be rotating around a geographical area within the School of Anaesthesia. Again, one of the advantages of us being very big, depending on where you're on the country, is that the geographical area that you rotate around might be comparatively small, as composed to, say, plastic surgery, which can be vast. So there's Kent, Surrey, Sussex, for example, is quite a big area. London itself is relatively small. Up north, I'm sure they've got some very big areas, but compared to some of the other specialities, they tend to be smaller. And the college, all the schools endeavour to move you around as little as possible. So hopefully you'll be staying a year or more in any one place before moving on.
Dr. Thomas, we have a few more questions.
Yes. So there was research. How important is research? I saw that one. It is important, not least because it's part of the curriculum. You do need to do some. It's all very much laid out in fact, one thing I haven't said yet is anybody that's considering anaesthesia, do just go to the Royal College site. It's if you search up RCOA or just Royal College of Anaesthesia, then it will become immediately obvious. And there's a whole, this entire discussion is there in assorted, very, very pleasingly well shot posters. So there's a load. Yeah, thanks, Megan. There's a load of stuff on there. Research, yeah, it has to be done. And again, generally speaking, we're trying to rationalize it so you don't get a load of ridiculous research. If you want to do the minimum, which is essentially where I came from, you just do the minimum. If you want to get involved in research, then you can get very heavily involved in research and end up doing fellowships and all sorts. So there's the full spectrum, but you do have to do some. And I think that's actually broadly true of all specialities post qualification.
My advice would be, if you're a final year medical student now, it's probably not the best idea to
don't worry about it.
A project at the moment. Whereas in F1 and F2, you'll be in your trust for 2 years, so it'll be much easier to get involved in impactful projects. My advice to everyone would be QI over research. It's easier to get published, it's easier to win prizes for, people get way more excited about it. I never really knew about it in medical school. You'll get loads of teaching and support about it in F1 and F2. But if you can do 2 good cycles of an audit for anaesthetics, say, for example, you want to increase the confidence of medical students doing like a basic anaesthetic procedure, and that's your QI project. You could run 4 sessions all about the ins and outs of intubating, take confidence intervals before and after every single one, demonstrate that you've done a teaching series, and then maybe like you want to do, I don't know, another intervention. You can do something really simple in medical school, or you can get involved in something a little bit bigger with other trainees but it's about kind of like being really efficient. So how can you hit a few birds with one stone and like branch out one thing and make it really good? Work in teams for all your portfolio stuff. Everything is better when done together. That is my experience. Projects last longer. They are more likely to get done. You've got a second pair of eyes. So if you've got a few friends who also want to apply to anaesthetics, work with each other, not against each other, because you achieve way bigger and better stuff, and you can all use it on your portfolios like independently. Again, sorry to interject.
No, you stop apologizing for interrupting. Yes, that's a very good point. A project can be on many people's portfolio. In fact, they've got, I can't remember what they're called. There are some massive projects going on which are involving literally hundreds of people. Pan London. There's a Pan London. There's a Pan London Anaesthetic Network, for example, and they have got somebody in every hospital, and they're looking at big questions, whatever they may be, which affect us all. I'm going to have a quick look at the questions now because I've finally worked out how to open it up. So I'm used Zoom in ages. Any tips for the interview? Now, apologies, I haven't really got any tips for the interview because I haven't done any HE interviews for ages, other than prepare yourself as much as you can. Think of what people will be asking you. They will almost always ask you something along the lines of tell me about yourself or talk me through your CV. They'll ask you why you want to be involved in whatever it is you're applying for, and they might well ask you it's all cliched. They might well ask you what might you bring, or things like that. But a lot of them, particularly for the just entrance for the stage 1 for CT1, I think there's a lot of structure involved. So if you, again, there are good resources on the college website as to what it will look like, the kind of thing they do. So get yourself onto the college website and have a little dig around on that.
Yeah, I've just sent a link. There's a 20-minute video where they literally go through the mark scheme for the interview. So obviously, like, wait till the end of this talk, but that video literally shows exactly how they score the interview. So watch it now and then work backwards and look at the kind of thing that you need to do essentially.
So teaching, so the vast majority is one-to-one teaching, as I've said. Right, that's right the way through training, which is hugely different to most other specialities. It's essentially apprenticeship teaching. You'll be in theatre with either a consultant or a senior trainee for certainly to begin with, and for a lot of your training thereafter. That's backed up with classroom teaching, with simulation, with regional training days, courses, etc. But in addition to that, the college itself has put together a load of learning resources on what used to be called e-learning for health, is now called COH. I can't remember what it stands for. Something of healthcare. Anyway, also there's some truly fabulous podcasts out there, but all of which are hosted on the Royal College website. So there's a whole load of resources out there for learning. Anybody that is successful and does make it in, don't be surprised. It is extremely tiring to start with, and there's a huge learning curve, not least because it is bizarrely, or at least as far as I'm aware, it's bizarrely different to anything you've done before, which ties into how little exposure that you get of it as at medical school. I'm quietly wound up about the fact that obviously you end up doing weeks and weeks, possibly even months of medicine and months of surgery, which have their own subspecialities, I entirely accept. And you end up doing 2 weeks, certainly in GKT, Guy's King's Tommy's, you end up doing 2 weeks of anaesthetics, ED, and critical care in total, during which time we have to get the GMC requirement of the male catheterization in, which also takes time away from it. It's like, oh, for goodness sake. So we all know that as well. So don't feel bad about asking that you need to do it. And yet, the vast majority of people who end up in a hospital will end up being anaesthetists. That said, everything that I used as an anaesthetist, I learned subsequent to anaesthetics. If I could have remembered all my physiology, that would have been really, really useful. If I could have remembered all my pharmacology, that would have been really useful as well. But the physiology that we do and the pharmacology that we do is a little bit more niche and sometimes a little bit more detailed. And you learn it all again. So you arguably don't need any of it from medical school, because you will be taught it again and you'll need to learn it again for the exams and for just general usage. And fairly obviously, I've forgotten the vast majority of it since I did my exams. But the bits that are still stuck in there are used in my day-to-day life. And that's why there is such a big learning curve, Megan.
Just a quick note, people asking about doing QI projects in final year of medical school. I would say no, I would not do that. Because you're going to move trust, so it's going to be hard to carry it on, and you're going to have to do them in F1 and F2, and you don't want to be applying it's better to have 1 or 2 really impactful projects in a trust where you've stayed at, and you've been able to give it to your mate to do another cycle of, and then give it to your other mate to do another cycle of, and then you get that really good continuity. But you get so many opportunities to do it because you have to do it. The trusts are like, right, who's doing what project? So don't worry about this. Another question for you, Huw. Are there opportunities to go abroad to work or train in anaesthetics in the short term?
Yes. So during that nominal 7 years, either you could just drop off and go and be foreign, move to Australia and carry on training out there. How much of it they'd recognise, I don't know. But once you have qualified, then again, there are opportunities to go out and work elsewhere. you'd need to double check with the GMC and or college as to who recognises what. In fact, no, you need to check with the country's colleges or registry bodies as to what counts or not. But fellowships are definitely a thing, and it's called an OOP, an out of program time. So it's either an OOP-T, so you go out and do some training. That would count towards your training. So you could go off and do a regional fellowship in Vancouver, and that would still count towards the 7-year total. You can do an OOP-E, which is for experience. That may or may not count. It depends on exactly where you go to do what you're doing. You could go for an OOP. There's an OOP-C, which I particularly like, obviously, an OOP-C. That is for, I can't remember what the C stands for. But anyway, the other types are you can just have time off. You can just take time out, which needs to be discussed with the school. But you could take 6 months out of training and go and do whatever you like. Go and sit on the beach, come back again. Or you could go off and do something very interesting which doesn't count for training, such as go and be an anaesthetist and train people in Uganda. I don't know, making up. But people do that kind of stuff. So there are definitely opportunities to step away and do something foreign or away and interesting and then come back again. Or indeed you could do an out of program thing within the UK. It's not a be all and end, a bit like an elective in that respect, I suppose. So yes, you can go away and do stuff, foreign stuff. We have obviously a very portable speciality, which is quite handy. And broadly speaking, we could work anywhere within the world, and you can certainly recognise it from a resource perspective. But we get a lot of people go out and work in very poorly resourced locations as well. Megan,
Another question regarding the current competition ratios and the fact that if trends continue, it will be a fight to the death to get a spot. Do you think training places will increase? Also, do you think there is a chance of the application process being changed from the MSRA to something anaesthetics based?
So that's the handy thing about me having relatively recently been in on the college tutor meetings. I do know that there is currently no plan to change the MSRA stuff, and in fact, they have been apparently they're pleased with it. It's been scoring well. It apparently has been choosing anaesthetists appropriately, whatever that means. So the scoring has been working for anaesthesia, so that'll be staying. With regards to training numbers, the college has been lobbying for more training numbers ever since, always. There is going to be, I forget the exact numbers, but in 10 years' time, there'll be something like a shortfall of 19,000 consultant anaesthetists. It's absolutely insane. We're currently running 19 short at Guy's and St Thomas's, with the current, attrition and projected increase of work and all the rest of it, which is one of the reasons why the non-doctor anaesthetists and ACPs and all that kind of stuff are being touted as a potential solution. We need many, many more. Apparently there is no funding for it. There's been a slight gradual increase in numbers. Some more are being released, but it's not much more. You're right, it's dog eat dog. It's not quite as bad as it was just post-COVID when they changed the curriculum and moved the goalposts and there was a lost generation, but it is still pretty ugly. It's very popular.
Another question from me. If you were to say something to a final year medical student who is dreaming of being an anaesthetist, what would your advice be?
One, go for it. Actually, wait, cynically, I'd say one, if you can, take your time before you make a decision. See what's there, because you might be wrong. But ignoring that, if you're dead set on anaesthesia, just try and get involved as much as possible. Look at the college website, see what they say, speak to more importantly, I'm old and crusty and no bloody good on these particular aspects, but find yourself some first year, second year core anaesthetists and speak to them about what they did and see if you can get any idea of how they were successful. They're the most valuable resource in that respect. So yeah, speak to the young folk.
Another question, Do you have any advice on how to become dual specialised in anaesthetics/ITU?
Yes, you can. I think you've got to start anaesthetics first. I'm just thinking about it before I say it. Yes, so you do core anaesthetics as you would anyway, and then you apply for SD4 in anaesthetics, and then around the same time you apply for ITU as well. And then thereafter you do dual training, which means it takes about 1 year more than that. And in the ST6 year, rather than doing a subspeciality, a specialist interest area of, for example, obstetric anaesthesia, regional anaesthesia, pediatric anaesthesia, you end up doing so you normally do two of those as an anaesthetist for a year, so it's a total of a year. You end up doing that. Your SIA is intensive care. So if you fancy doing dual, then yes, start off being an anaesthetist, and everything else will become very apparent along the way. You'll also get an idea of whether you like anaesthetics or not along the way, because as part of core training, stage 1 training, there you do 6 months of intensive care. If you don't do dual training, you will do a further 3 months of intensive care in stage 2, so you end up doing a total of 9 months. If you do intensive care, obviously you do a lot more, and they will rotate you out of anaesthetics in order to do acute medicine, more intensive care, as part of the intensive care training. Basically, do it via anaesthetics.
The next question is, is there talk of phasing out the core anaesthetic pathway completely and only having an ACCS STEM, or is this just a rumour?
Not as far as I'm aware. There is talk of, as I think I said, there is talk of making it run through. But I'd be very surprised if they do ACCS only.
And what do you think the future of anaesthetics looks like, from like obviously being a bit more experienced and involved in the Royal College?
So my head's bouncing around with two thoughts of one, just, what we do, drugs, all that kind of stuff. And in that respect, I'm not convinced a huge amount is going to change. There'll be some big stepwise shift in not using propofol or whatever. But broadly speaking, anaesthetics as a skill will be similar, I suspect. I think there will be more of a move away from a purely doctor-led service. I think it's almost inevitable that there will be what they're called. We have an anaesthetic associates, the equivalent of the ACCPs or the AHPs or whatever they are, allied healthcare. I can't remember. But anyway, so more non-doctor anaesthetists, and that would tend to, I imagine, work in a way where I would be supervising two of them, or an anaesthetic trainee and one of them, or they're working directly with me in theatre, being helpful, doing lines, or doing intubating whilst I'm also in there doing other aspects of the anaesthetic. So I suspect that's how things will change relatively soon. Certainly, I would imagine by the time you guys qualify as consultants. Not least because we need more bodies. I would, technology-wise, I suspect there'll be more AI involved, and in that respect, I mean, we'll have feedback loops. So currently, I've got a pump with a computer inside it that makes various assumptions once I put the height and the weight and the age of the patient in, and I then choose what levels I want the pump to assume it's putting in. It's worked out the levels in the system. We'll start getting feedback loops whereby the amount of the concentration is measured in the bloodstream. There's a feedback loop through the computer, and then it will then adjust much more accurately up or down as to what's going on. Now, ultimately, you could argue that would take us completely out. It might do ultimately, but it's going to be a long old time because there's going to be a lot of nuances which are going to be very hard to program into that. Not least because we don't necessarily want everybody to be at the same concentration, because the human body reacts in different ways. So, but that's something else I could see coming in technology-wise. And in terms of very simple one, it's coming. Everybody's going to be doing video laryngoscopy in the UK. Ultimately, we're all still doing the old school direct laryngoscopy. So that's looking at the vocal cords and pushing the tube through it using a handheld thing with a light on the end. So I do that. I can see the vocal cords, whereas a large amount of it now is done on video. So we have a very similar thing we stick in the mouth, and I'm now looking at the screen like that and doing it like that, which is safer and arguably much less potential damage for the patient. So that's definitely coming in, and we're moving over to it a lot in Guy's and Tommy's. In fact, they've already done his Bath. They're completely video laryngoscopic at the moment. So that's futury stuff.
So maybe if you just have a leaving note for everyone, Huw, or if you've got any kind of final tip.
I don't know about a tip, but certainly one thought is, I mentioned a long time ago that when I looked at the A&E consultants, when I was doing A&E and the PEDS consultants, I looked at them and I thought that their life was actually quite different to what I was doing on the ground at the time. I was really enjoying doing clinical PEDS, I was really enjoying doing clinical ED, but their consultant roles were very different. And I think that's less so as a consultant anaesthetist. I think as a consultant anaesthetist, we still do a huge amount of stuff that we do as trainees. There are definite differences. We do less striding around the corridors, saving the day, because that's what our senior residents are doing. But we have a much more steady week by week life. And in addition to that, we obviously move more from educator to learner, but we're still learning the whole time. But yes, I think what you see is what you get more as a trainee resident anaesthetist is what you see as a consultant anaesthetist. I don't know. The job remains more similar, and by that I don't mean it remains boring. I mean it doesn't mean you're going to train for one thing and end up doing another. You inevitably end up doing more paperwork, helping to run the department, looking after trainings, what have you. But we do have time allocated for that. We get paid for that, generally speaking. Quality of life, do it. Anaesthesia, it's great.
And thank you again, Dr. Thomas, for taking time out of your busy schedule to get this for us.
It's been a pleasure, and good luck to you all. Anybody that doesn't want to be an anaesthetist, I utterly respect that, because we do need loads of other people doing loads of other specialities. But if you think you're going to be right for it, go for it, because we need more anaesthetists too. And anaesthetists are awesome.